So, how to assess diastolic function of, on echocardiography? When I do my scan, I feel like a cardiac surgeon, and my surgical knife is the probe, and with my probe I cut the heart from different point of view, and then I analyze every cut I do. So one of the most popular cut of the heart is the apical view, where you cut the heart from the right to left. So you will cut the heart that you need to think that is like a big aubergine, you cut it, and then you split on two halves, which are specular each other. And you will get the ventricle at the bottom, and at the top you get the atrium. But, sorry, have you got a pointer? No. Over here, okay. But the way how you look at the heart on the echo machine is turned on the other way around. So you will get the ventricle at the top and the atrium at the bottom. So this is how our heart appears on the four-chamber view. Okay? So it would be easy to understand that our heart is like our apartment, holiday apartment, with four chambers. And the biggest chamber is the living room, is our left ventricle. And this is the left ventricle, and then we will get the left atrium with the right ventricle and the right atrium. Okay? But if we talk, but hypothetically, we could split the heart in two parts, the right side and the left side. And from the cardiovascular circulation, we already know that there's no connection, direct connection between the right and the left. So we can put the right heart on the right lung and the left heart on the left lung. Because the right lung works with the lungs, so a low pressure system, and gets the blood from the venous system. Where the left heart works with the systemic pressure, so high level of pressures, and gets the oxygenated blood from the lungs. But if we need to talk regarding diastolic function, systolic function, we need to focus our talk on the left ventricle, on the living room of our apartment. Okay? So this is how our left ventricle appears on the apical view. My probe is here, left atrium, mitral valve, and left ventricle. We already know that the heart is continuously beating and is a play of pumping and filling. It's refilled by the blood coming from the body, and it needs to pump out into the body the blood. So our cardiac cycle will be divided on two steps. The first step will be systole, and the second step will be the diastole, where the diastole is much longer compared to the systole. Diastole filling part, systole is pumping part. And to understand systole, to understand diastole, we need to understand systole. So it's a continuous play between volume and pressure, where at the beginning of the systole, the LV cavity will be plenty of blood, will be the maximal volume of blood inside the LV cavity. And along the systole, this volume of blood will fall. And then there's the pressure. And the pressure again at the beginning of systole will be very, very low. And during the systole, because of the action, because of the squeezing of the walls, we go sky high. So volume down, pressure high. And how are we used to assess the performance of our left ventricle? Well, in the last 10 years, that was the Simpson method. I'm sure that you know it. and now there's the 3D data set in the last few years. 2D and 3D acquisitions. And more technologies are coming along, and one will be the global longitudinal strain, the spectral tracking, and we know that in a few years maybe they will overcome the ejection fraction. So now we know what is systolic, and we can move on to diastolic. If we talk about diastole, we talk about relaxation and feeling and dynamics of the feeling of the left ventricular cavity. And the normal diastolic function allow adequate feeling of the LV cavity without raising too much the pressures in the LV. So let's see how it works. Do you remember systole was volume down, pressure high? On diastole it will be the other way round. So it will be that the volume at the beginning of the diastole will be very low because the amount of blood inside the LV cavity will be very low. And during the diastole, this volume will go up because of the filling of the cavity. And what happened then to the pressure? Well, the pressure will be a little bit different because the pressure of the inside the LV cavity will be sky high at the beginning of the diastole because the diastole is following the systole. And then during the isovolumic resection time will fall a lot. And the pressure will go down even lower compared to the LA pressure, left atrium pressure. So, how the left ventricle will be refilled by the blood? 3 steps: rapid filling, diastasis, and arterial contribution. Rapid filling will be here. Will be a passive flow of blood from left atrium to left ventricle. Why is it passive? Because the LA pressure will be higher compared to the LV pressure. So there will be this flow, easy flow into the LV cavity. This flow will stop when there will be an equalization of pressure between left atrium and left ventricle. Diastasis. And then at the end of the systole, and at the end of the diastole, you will get the atrial kick, the contraction of the left atrium. And so, how will we translate on an echocardiographic point of view all these dynamics? With a pulse wave Doppler, you put your cursor of the pulse wave in between the tips of the leaflet and mitral valve. Okay, you are on the 4-chamber view. Sample volume will be between 1 and 3 millimeter. You must be parallel to the flow. And then you need to make the adjustments to your machine, filter gains and scales, of course, velocity scales. And what happened that you get 2 waves, E wave and A wave. E wave is the passive flow because it comes from this pressure gradient between LA and LV, and then the kick of the atrial, which is the atrial contraction at the end of the diastole. Okay? 2 waves. But what happened then if you got a diastolic dysfunction? See this old experiment, Dr. Flushkamp, 1992. So 2 boxes, one is full of water, the other one is half empty of water. There's a connection between these two boxes, and then this connection is open, and then by gravity, the fluid goes from the first to the second box. And you can measure it with your pulse wave, and you will see that you will get a deceleration time, which is the time in which the pressure will be equalized in between the two boxes. So it will be long. But if you put a solid object inside the second box and then you open the connection between the two boxes, then the time in which there's the flow in between box 1 and box 2 will be shorter. So your deceleration time will be much shorter compared to the previous one. This is because you have a reduced compliance of this second box. And this happens with the diastolic function. Okay? And let's see what happened. This is the normal LV curve and LA curves, or pressure curves. And this is the normal pulse wave Doppler, EA and A waves. So if you got an abnormal relaxation, there will be a delay in this fall of pressure from the left ventricle. So it will take longer. And so you will get an inversion of EA waves. This comes along with the age. It's not always a disease, okay? Older people has this problem. But if the pressure is too high, the filling pressure will be sky high. So we will get a very tall E wave and very short A wave, and the deceleration time will be shorter. And worse is the feeling of, higher are the pressure inside the LV cavity, worse is the prognosis for our patient. So, along with the increase in diastolic dysfunction, we will move from normal to restricted pattern. And see how the E wave at the beginning will be shorter, taller, and then will go higher and high, where the deceleration time will be shorter and shortened, for the reason that we already seen in the experiment. And the atrial kick will be shorter as well, because the pressure in the left ventricular cavity are so high that the kick of the artery, the contraction of the artery, is not enough. Limitations of the pulse wave Doppler. Well, is related, is challenging if you got atrial fibrillation or first degree AV block, pacemaker, ICD, and so on. Everything that go and affect the rhythm of the heart. If you got the fusion of E and A waves, sometimes happen, especially in the humans, if the heart rate is very high. If it's age dependent, we see every time with decrease in the age of patient, and if there's anything that damage the LV cavity, the muscle, the cardiac muscle, MI, myocarditis, and so on. So the elastic recoil, which facilitated all these flows, is damaged, is abnormal. So these are the last guidelines, American guidelines, recommendations on diastolic function, and there are 4 degrees, normal, grade 1, grade 2, grade 3. Let's see how the EA ratio is described. So it's normal, is over than 0.8, grade 1 is less than 0.8, is severely abnormal is more than 2, and then there's a gray zone between 0.8 and 2. And these numbers are quite easy to get. Let's see in the normal life. This is a 27 years old football player, 4-chamber view, left ventricle, left atrium, right ventricle, normal, normal ejection fraction. If you check his filling, mitral filling, you will get a normal E wave and A wave with a ratio of 1.3 and normal deceleration time. So this is a normal case, okay? "75-year-old lady, dilated cardiomyopathy. She decided, well compensated, well treated, but she decided on Christmas to stop her medication. So she came up in our lab 2 weeks ago, and this is her left ventricle. It's dilated and severely impaired. Ejection fraction here is around 30%. Don't forget that if you got systolic dysfunction, you will got diastolic dysfunction. So I'm sure that her diastolic dysfunction will be, I'm sure to find the diastolic dysfunction, I need to understand the grade of her diastolic dysfunction. So, pulse wave Doppler. Very tall E wave, very short A wave, ratio 2.3, deceleration time is 105 milliseconds. So she's got severe diastolic dysfunction. Okay? I think that you are quite happy with this heart rate, because if you get this heart rate on mice, it means that they are almost on cardiac arrest from severe bradycardia. So, third example, 42, 43 young chap, long history of hypertension. He's got aortic coarctation. He's good. And he came in our echo lab for his usual echo. And what we found that E wave and A wave with a ratio 1.3 and an acceleration time of 150. Pretty good. So it's normal. But the history of this patient is not a normal history. He's 42 years old, and he was born with aortic coarctation. So he's got high blood pressure in the last 40 years. And he's taken lots of medication about against his blood pressure. So can be this pattern. And what we did a Valsalva maneuver, and we saw that there was an inversion of the E-wave ratio. So a diastolic dysfunction was masked, and it was unmasked by the Valsalva maneuver. What is a Valsalva maneuver? It is a forceful expiration against closed nose and mouth, as they do the scuba the divers, just to compensate. They do it this way, and they do the Valsalva maneuver that reduce the LV preload and unmask the relaxation, the abnormal relaxation. Of course, you need to get an EA ratio change more than 0.5, which is highly specified for increased LV pressure. Move on, and from anatomy we know that the filling of the left atrium is coming from the pulmonary veins, okay? So sometimes we need to scan the pulmonary veins to understand, and this is the curves of our pulmonary veins, a systolic curve and the diastolic curve, D wave and A wave, which is a reversal flow into the pulmonary veins. So how do you do that? You need to put the four-chamber view, you need to use the zoom just to see where the pulmonary vein are. And pulse wave again, sample volume 1 2 millimeter, oh this is not correct, it's 1 2 millimeter into the pulmonary vein. You must be parallel to the flow. And again, the usual adjustments. And you will get these three waves. Systolic flow velocity, diastolic flow velocity, and then you got an atrial reversal velocity. And then you get another data coming from this A wave, the duration of the A wave. So, normal diastolic function, normal ratio A wave, and normal waves, SD and A. And the duration of A wave is shorter compared to the A wave coming from the mitral flow. Okay? But if you got very high pressure in the LV cavity, the atrial kick will struggle because the high pressure in the LV cavity. Okay? So it will last less compared to before. Okay? So your reversal flow will be much longer compared to the normal. Do you understand? Okay? So sometimes this will help you to understand if there is a real dysfunction, diastolic dysfunction or not. It's a question of duration of this wave. What we use again is the tissue Doppler imaging. Tissue Doppler imaging, it studies the movement of the muscle. The muscle is not a flow, it's not a blood flow, it's a movement of the muscle inside the wall. So, four-chamber view, you will get this TDI from the septal or from the lateral wall, it depends. So you can do even the septal and even in the lateral wall, and then you can do your average. And cover a longitudinal excursion, so you need to be almost parallel to the excursion of the left ventricle. Don't forget that the left ventricle have an excursion from the mitral valve to the apex, in this way. So you need to measure this excursion. Align cursor parallel to the motion of the annulus with sample size 5 to 10 millimeters and machine adjustment, as we know. And what happened? That you will get your waves, S wave, E wave, E prime wave, A prime wave. Okay? And if you do the reverse of your waves, you get your mitral pattern. Okay? But don't forget that your mitral pattern that you are used to is blood flow. This is muscle movement. Okay? But it reproduces in some stage the same movement of the blood flow. So, what happens during diastolic dysfunction? Diastolic dysfunction increase, deteriorate, and you will get the usual slopes that you saw before. And for the TDI, again, you will see that the E prime will be shorter and shorter. Okay? And the A prime will be not affected that much. Do not forget that there are few differences in between the septal and the lateral walls. Lateral walls is usually more energetic, is better than the septal. Limitations, TDI limitations. different cutoff values depending on the sampling site for the measurement. As I told it, septum against lateral wall. Age dependent, but we know that diastole is age dependent. And TDI is useless if you got mitral calcification, surgical rings, prosthetic valves, which is quite, for humans, is quite used to get this problem. I'm not sure that for mice or animals you will get prosthetic valves or surgical rings. So let's see what happened with the guideline. Average E over E prime ratio, normal under the 10, grade 1 dysfunction under the 10, severe dysfunction over 14, and impaired grade 2 in between 10 and 14. Septa cutoff for the grade 3 is 15, for the lateral cutoff is 13, so they did the average of the two data, so 14 came out. So the two cornerstones are 8 and 14, normal under than 8, severely abnormal over 14. So 55 years old, history of ischemic cardiomyopathy, he's got bypass, and very high blood pressure. His left ventricle is very heavily hypertrophied. Okay. There's a heavy hypertrophy on the left ventricle, which is quite dilated. So, pulse wave Doppler will be like this, and we got almost a fusion between E and A waves. So it's not that easy. And the TDI in the septal is almost fused. Specular to this, okay? I tried to force, I tried to get my numbers, and I found 0.4 E wave, 1.0 A wave, so the ratio is 0.4, and the deceleration time 120, where the E over E prime is 13, which is in the gray area. Remember, 8 normal, 14 is severely abnormal. This is 14, and we got fused waves, almost fused waves. So we need to pay attention that sometimes this number can be confusing, because I'm sure that this patient will get a very severe diastolic dysfunction. I know it because his pulmonary pressure is very high. So this is confusing. If you don't get nice waves, you need to pay attention. "48-year-old woman, short on breath, no cardiovascular risk factor. Left ventricle has a normal function, normal ejection fraction, but again, his hypertrophy is very, very important. Pulse mitral inflow, very tall E wave, very short A wave, okay? 1.0 over 0.2, okay? So E prime, very short E prime, and very short A prime. So the ratio is 25. So she's got very high pressures. She's got severe diastolic dysfunction. Because this woman has cardiac amyloidosis. So her muscle is infiltrated by amyloid. Okay? How can we assess again our diastolic function? Sometimes it happens that the tricuspid regurgitation velocity is very helpful because we can get very high pressure in the lungs. And this high pressure in the lungs, most of the time, are related to LV systolic or diastolic dysfunction, or the both together. So we put our cursor, CW cursor on the tricuspid regurgitation. We get our velocity, and then using the simplified Bernoulli equation, we can get our pulmonary artery pressure. And how guideline, which is the position on the guideline for the TR velocity is here. So again, 2.8 is the cornerstone, less than 2.8 is normal, over could be significantly abnormal. Okay? LA volume index. This is the area of the LA or the left atrium. You can get it tracing the area or as a volume, and this is like the Simpson for the ejection fraction. You do your volume on systole and diastole on 4-chamber, 2-chamber view. Again, the left atrium is related with the diastolic dysfunction. LA dilatation, of course, is related with diastolic dysfunction. Limitations are LA dilated is if the patient has severe bradycardia or high put-out states like pregnancy, atrial flutter fibrillation, mitral valve disease, despite normal diastolic dysfunction. If you are an athlete, you get good chance to have your LA dilated. And then again, if you are going to measure the LA dilatation, you need to pay attention to the LA for shortening. Current guideline, LA volume, and again, if you got diastolic dysfunction, LA volume will be increased. So this is what we use. This is my last slide. This is how we use all this data for assess the diastolic function in our patients. So if the ratio E over A is more than 2, we are sure that there is a significant diastolic dysfunction, and if the rate of E and A is less than 0.8, we are sure that there won't be any diastolic dysfunction. The problem will be in the middle, in the gray area. So we need to integrate the ratio of EA with E over E prime ratio, or TR velocity, or the volume, or LA volume, which needs to be indexed for the body surface area. And then we will use, if the patient have 2 or 3 or 3 or 3 positive, then you will get of these 3 data, we will get the diastolic dysfunction. So, as conclusion, assessment of diastolic function is challenging and complex. Technical skills are critical. We need to make sure that our data are concordant. It's not just one data that gives you the diastolic dysfunction, but it needs to be a mixed group of data. So non-singular parameter can replace careful thought. So if you think that the patient has diastolic dysfunction, you need to look for it. And we need an organized approach. Finished.